Yes, streaming live.
We are live on YouTube, ma'am. This is Ranjit Sahu, Marketing Head with Bushnell. Welcome you all to this lively webinar on endometriosis and infertility on this lovely evening of 17th September. We have with us Dr. Yazhini Selvaraj, the eminent doctor of Madurai. She is MD, D.G.O, FICOG, DRM, Germany. She is former assistant professor of Gynae Department, Madurai Medical College. She is the managing director and chief consultant gynecologist, IVF specialist, and of Pony Fertility and Research Center, Madurai. So she will be talking in a very interesting topic, that is endometriosis and infertility. With this, I hand over the session to Yazhini Selvaraj ma'am to take it forward. Over to you, ma'am.
Thank you so much for your kind words, sir. At the outset, I'd like to thank the Walter Bushnell, Dr. Ranjit Sahu, Anish Ravi, and Mr. Saravanan. Sorry, Mr. Ranjit and Mr. Anish, and Mr. Saravanan for giving me this opportunity to deliver my speech on endometriosis and infertility. Endometriosis, as we know, it is it's an enigma, and it is renowned for its association with infertility and also recurrence that poses a lot of problem. And the prevalence, it is found predominantly in women of reproductive age group, and estimated more than 200 million women worldwide and 29 million women in India suffer from endometriosis. 50% of infertile female have endometriosis, and the exact prevalence is unknown. It has a greater association with infertility, and the biologic mechanisms that might link endometriosis to infertility are the distorted pelvic anatomy, altered peritoneal function, altered hormonal and cell-mediated function, endocrine and ovulatory abnormalities. It is associated with the impaired implantation, oocyte. It affects the oocyte and embryo quality, and also produces abnormal uterotubal transportation. The causes for infertility due to endometriosis or ovulatory dysfunction, as I already told us, it produces abnormal folliculogenesis, anovulation, luteal phase defect, luteinization of unruptured follicle syndrome, and the immunological alterations leading on to decreased sperm survival, altered immunity, the peritoneal factors, intraperitoneal inflammation. There is local production of prostaglandins and cytokines. It also interferes with the implantation due to endometrial dysfunction. Some mechanical factors like anatomical distortion of the tubes, altered tubal motility, and the peritubal adhesions which interfere with the ovum pickup. And there is interference with the coital function due to dyspareunia. We all know that endometriosis is associated with the deep pelvic pain, and which causes the dyspareunia. And there is sperm inactivation, phagocytosis by macrophages. You have ovarian damage or in endometriosis, and the mechanism is attributed to inflammatory reaction and mechanical damage. There is increased numbers of immune cells, elevated levels of cytokines, chemokines, and reactive oxygen species, and tissue fibrosis which are caused by the inflammatory reaction. And there is compression and stretching of ovarian tissue, hampered blood circulation, and there is disturbed neovascularization, which is caused by the mechanical damage. For a definitive diagnosis of endometriosis, visual inspection of the pelvis at laparoscopy is the gold standard investigation, unless disease is visible in vagina or elsewhere. The diagnosis may be delayed, and an average of 7 years is the delay time, on which depends upon the healthcare settings. The positive histology confirms the diagnosis of endometriosis. Negative histology does not exclude it. Whether histology should be obtained if peritoneal disease alone is present is controversial. Visual inspection is usually adequate, but histological confirmation of at least one lesion is ideal. In case of ovarian endometrioma, when the size is more than 4 centimeters in diameter and in deeply infiltrating disease, histology should be obtained to identify endometriosis and to exclude rare instances of malignancy. We have a simple fertility index scoring, that is the endometriosis fertility index, which is a simple, robust, and validated clinical tool that predicts the pregnancy rates after surgical staging of endometriosis. Its use provides reassurance to those patients with good prognosis and avoids wasted time and treatment for those with poor prognosis. In this, we take into account 2 scores. That is, one is the least function score, which is scored at the conclusion of or the end of the surgery, that is laparoscopy. We take into account the fallopian tubes on the left and right, embryal ends, then ovaries on left and right. If all these things are found to be normal, we score them as 4. If there is mild dysfunction, we score them as 3. If there is moderate dysfunction, it is 2. And if there is severe dysfunction, we give them 1 point, that's 1. And if suppose there is frozen pelvis or the absent ovaries or non-functioning tubes or fimbriae, then you score them 0. And we also have the historical factors like age. If the age is below 35, we give a score of 2. And if the age is between 35 and 39, we give a score of 1. And if the age is above 40, the score is 0. And the years of infertility is taken into account. If it is less than 3, we give 2 points. And if it is more than 3 years, it's 0. And the prior pregnancy status. If they give a history of prior pregnancy, then we score 1. And if there is no history of prior pregnancy, then we have to score it 0. So the least function score on left and right is added, and the historical factor score is added to this, which gives the value of the endometriosis fertility index. If the index is between 9 and 10, then the pregnancy rate will be around 80%. And if it is between 7 and 8, it is less than between 60 to 70%. And as the score goes down, the pregnancy rate also goes down. So what is the treatment modality that is available to treat this endometriosis? To have the medical management, surgical management, sclerotherapy, about which I will be talking later. Then if the AMH or the antral reserve is very poor, then we have to go for intrauterine insemination and IVF or ART. Ovarian suppression for fertility is achieved with the gonadotropin releasing hormone agonists, progestins, danazol, oral contraceptives. All have been shown not to improve the fertility in women with endometriosis, but to suppress only ovulation. So such treatments seem rather to postpone pregnancy and imply side effects. Clomiphene and letrozole are commonly used drugs for ovarian stimulation. The efficacy of ovarian stimulation isolated from other procedures in endometriosis-associated infertility remains to be documented. There is the medical therapy. It's a rationale to induce amenorrhea and create a hypoestrogenic environment, theoretically inhibiting the growth and promoting temporary regression. The side effects may be intolerable for some. The symptoms recur upon cessation of therapy, and fertility is completely eliminated during treatment, as medical suppression inhibits ovulation. Selection of medical therapy depends on the therapeutic effectiveness, tolerability, drug cost, patient experience, and expected patient's compliance, effectiveness, tolerability, drug cost, and patient experience, and expected patient's compliance. Sorry, it's repeated. The sentence is repeated again. The current medical therapies are hormonal contraceptives, gonadotropin-releasing hormone, danazole, and non-steroidal anti-inflammatory drugs. The newer hormone that is used are the GnRH analogs, leuprolide, naferilin, goserelin, triptorelin, and GnRH antagonists, linsogolix, elagolix, and relugolix. About the progestins, you have the depomedroxyprogesterone acetate, danazole. It is not used nowadays, nor ethisterone acetate, Dynagest, retroprogesterone, that is dydrogesterone, levonorgestrel, impregnated intrauterine devices, and etinogestrel implants, which can be used subdermally. Aromatase inhibitors like letrozole, 2.5 milligram with norethistone 5 milligram, anastazole 1 milligram plus 200 milligram of progesterone. All can be tried, and the disadvantage are it decreases the bone mineral density and it causes hot flashes. Selective estrogen receptor modulators like tamoxifen, raloxifene, and benzodoxifene can be tried, and selective progesterone receptor modulators like asuprasnel and telaprestone can be tried. You have the estrogen receptor ligand, estrogen receptor alpha and beta. So these are all the newer things. The anti-inflammatory drugs, we know that there is angiogenic inhibitors, that is the VEGF and matrix metalloproteinases, and endometriotic implants grow in ectopic locations with a new blood supply. So you have to curtail the blood supply to treat this endometriosis. You have this TNP-470, which is derived from aspergillus, and endostatins derived from factor 18 collagen. Dopamine agonist, gabergolin, in the dose of 0.5 milligram, given inhibits the neuroangiogenesis. Rapamycin, doxycycline, and PPARs, that is rosiglitazone. All these things can be tried. And drugs under research are the immunomodulators like loxoribin and interleukin alpha 2, tumor necrotizing factor alpha inhibitors, and retinoids. The pain management can be tackled with gabapentin, amitriptyline, and antioxidative drugs like resveratrol, and the future direction is targeted to genes and genomics. So what are all the current limitations of these therapies? The major limiting factor of the currently available drugs are their adverse effects and the ability of the patient to tolerate them. There is still dissatisfaction present among patients regarding the effectiveness of therapies and its impact on their lives. Dynagest, as we all know, is a synthetic oral progesterone with an unique pharmacological property, and there is no androgenic side effects, but it has a good progesterogenic effect on the uterus. It has a favorable safety and tolerability profile. The limitations of Dynagest, as about the other drugs also, pregnancy can't be achieved during its course. It's an expensive drug for the developing and underdeveloped countries because it ought to be continued for a longer time, say around 12 to 24 months. Medical therapy is non-specific, non-curative, and aimed at alleviating symptoms till menopause or until pregnancy is desired. So this is the guidelines for the surgery of endometriosis-associated infertility. So according to the ESHRE, that is the European Society of Human Reproduction and Embryology, and the American Society of Reproductive Medicine, these following guidelines are portrayed. The minimal or mild endometriosis is the objective of surgery is to destroy or remove all or most of the endometriotic implants. And according to Cochrane Library, there were 2 meta-analyses published in 2014, which concluded that removal or destruction of endometriosis improves fertility and the pregnancy rate also improves. And this was an article published in New England Journal of Medicine, where 341 infertile women aging between 20 and 39 with minimal or mild endometriosis underwent diagnostic laparoscopy, and during diagnostic laparoscopy, some of them also underwent resection or ablation of visible endometriotic lesions. And they were all followed up to 36 weeks. And after the laparoscopy, and for those who became pregnant, they were followed up to 20 weeks of pregnancy. So among the 172 women who had resection or ablation of endometriosis, 50 became pregnant and had pregnancies that continued for 20 weeks or longer. And so it infers that laparoscopic resection or ablation of minimal and mild endometriosis enhances fecundity in infertile women. One may question whether a 30% cumulative probability of becoming pregnant during 36 weeks justifies surgical treatment when one single IVF attempt will usually have a similar success rate. For moderate and severe endometriosis, the goal of surgery is to restore normal anatomy of pelvis and remove the large endometriomas. No randomized control trials on the effect of surgery in women with moderate or severe endometriosis associated infertility versus medical and or no treatment is available. Meta-analysis on observational studies suggested that laparoscopic surgery was superior to medical treatment or no treatment in endometriosis, but the stage of the disease was not reported in many of the included studies in that paper. Medical treatment before or after surgery, according to Cochrane Library, there is no evidence of benefit associated with post-surgical medical therapy and insufficient evidence to determine whether there is a benefit from pre-surgical medical therapy with regard to the outcomes evaluated. Then for small ovarian endometriomas, which are less than 3 centimeters in diameter, you can do laparoscopic drainage or electrocoagulation. That is, it is aspirated and irrigated and inspected with the ovarian cystoscopy for intracystic lesions, and the mucosal lining of the cyst wall is destroyed by vaporization. Large ovarian cysts or endometriomas greater than 3 centimeters in diameter can be aspirated and excision and removal of the cyst wall done. So cystotomy of endometriomas involves the opening of the cyst using either scissors or electrosurgically or using laser energy. So the surgical treatment is the mainstay of endometrioma measuring more than 5 centimeters. Laparoscopic excision of the wall of endometriomas should be considered as the procedure of choice. Concerns have been raised as to the possibility that surgical excision may damage the ovarian reserve. But recent evidences demonstrates that part of the damage may be due to the presence of endometriosis itself. The indication for surgical treatment should balance between the advantages and disadvantages. The advantages of surgical treatment are satisfactory pain relief, increase in the pregnancy rate, obtaining a tissue specimen for ruling out any rare cases of unexpected malignancies. And the disadvantage is the damage to the ovarian reserve. What are the limitations of surgery? In patients who fail to conceive spontaneously after surgery, ART is more effective than repeated surgeries. Following surgery, the ovarian reserve may be reduced as determined by AMH. In women with large endometriomas, more than 5 centimeters, the ovarian endometrioma should be removed. In women who have failed ART, further management remains controversial. Now comes the sclerotherapy. We need not keep on doing surgeries for endometriomas, which is a recurrent problem. Since if you do a metriculous surgery in the first attempt itself, restoring the peritoneal anatomy and ablating all the endometriotic lesions, then the recurrence rate will be very minimal and the achievement of pregnancy will be more. But many times it is not happening and patients are coming with a recurrent endometriomas. And I have the patients who who came even after 3 surgeries or 3 or 4 surgeries for endometriomas. So here comes therapy that is called sclerotherapy for rescue of such patients. And the known sclerosing agents are ethanol, tetracycline, and methotrexate. The newer sclerosing agents are leuprolide, cefoperazone, sulbactam, interferons or interleukins, recombinant interleukin 2, and metronidazole. So what is sclerotherapy? Sclerotherapy was originally used to treat tuberculous peritonitis and is currently used by medical oncologists to treat malignant pleural effusion. In India, it's often considered the treatment of choice for small varicose veins, and it is practiced in Delhi. It involves injecting a solution directly into the vein. The sclerosing solution causes the vein to scar, forcing blood to reroute through healthier veins. The collapsed vein is reabsorbed into the local tissue and it eventually fades. So why is this sclerotherapy? In the year 2016, April, I had a patient with severe endometriomas. I think there were 3 endometriomas, large one. And she had undergone 3 surgeries prior to her visit to me. And the last surgery was just 3 months ago. And herself and her parents were entered my cabin. And they told me that their husband and in-laws said that she will be divorced if she doesn't become pregnant within a year. So they were actually sobbing in my cabin. So the plight of this patient triggered my empathy towards her and made me search the internet for an alternative therapy for endometriosis, which can give a quick relief and resume fertility at a shorter time. Then I came across a terminology called sclerotherapy, which was practiced in US, Japan, Taiwan, Canada, and Israel. Before that, I have never heard of a terminology like sclerotherapy, and it was not mentioned in any of our books, and nobody have presented anything about that. So what is the mechanism of sclerotherapy? The cellular mechanism involved in sclerotherapy of ovarian endometriomas are not fully known, but it seems that epithelial cells lining the cyst wall play an essential role when adequate contact between the sclerosing agent and the cyst wall is achieved. There is activation of coagulation cascade and production of mediators for inflammation causing fibrosis of epithelial lining cells, leading to cyst wall adherence and obliteration of the cyst. And there might be enhancement of cytotoxic activity of macrophages and natural killer cells to suppress the endometrial activity. So this is a novel, cheap, simple OP procedure. And in developing and underdeveloped countries like us, where people can't afford much for medical management and repeated surgeries, I tried this newer modality for treating endometriomas. And what are the criteria for selection of patients selection towards this therapy? Women of reproductive age group were selected, And infertile or those who have yet to complete their family were selected. And there should not be any associated pathology like fibroids. And patients should be suffering from recurrent endometriosis or recurrent endometriomas, or would have undergone recurrent surgeries or repeated surgeries. And those who belong to stage 3 and stage 4 were taken for this therapy. Now we'll move on to the procedure in sclerotherapy under aseptic precaution, under antibiotic arrangement, which we start from the previous day itself. The endometriomas were aspirated sequentially using a needle of 17 gauge 35 centimeters long. We flush with the sterile saline until the aspirated fluid was clear. Using the Kraft aspirator guided by transvaginal ultrasonography. An injection of leuprolide 1 milligram and 100 milligrams of cephalosporin sulbactam were injected after completing the aspiration. And the dose of this depends upon the size of the endometriomas. And the largest endometrioma which I have aspirated was around 850 ml. In case of thick and old endometriomas, aspiration was achieved using 16 gauge and 35 centimeters double lumen aspiration needle, wherein through the other lumen we inject normal saline, dilute the thick endometriotic fluid, and then facilitate the aspiration. This was conducted as an outpatient procedure, and in very few apprehensive patients, either we used IV sedation or mild anesthesia was used. Otherwise, we used only oral anesthesia, because these patients are suffering from severe pelvic pain. And as I was aspirating, most of the patients, they go for they snore and they go to sleep. These are some of the endometriomas which we have aspirated. And this is the OM aspiration needle, the single lumen and the double lumen, and the Kraft suction pump. This is the procedure under ultrasound guidance after doing the vaginal toileting and under antibiotic coverage. Using the OM pickup needle, using the probe guide, we just enter into the endometriotic fluid cavity, and then we aspirate the endometriotic fluid. If suppose it is thick, use the double lumen, we inject saline and dilute the thick endometriotic fluid, and then achieve the complete evacuation. After completely evacuating the endometriotic fluid, we inject saline till the aspirated fluid becomes clear. And then, without removing the needle, we inject the sclerosing agent into the dead space. So this is an ongoing prospective pilot study that included so far 110 patients, and it was carried out in Pune Hospital and Mother Fertility Research Center from April 2016 till date, and it showed impressive results. Because of the corona, we couldn't do much of sclerotherapy for the past 2 years, and but even today I did one case, and also day before yesterday. So far we have done 112 aspirations. 51 were infertile and 59 were parous women. 43 patients have completed their family. Complete resolution was observed in 102 out of 110 patients, giving a success of 92.72 at follow-up examinations. 4 patients didn't show up for follow-up examinations. Repeat aspiration with leuprolide was needed in only 3 patients. 1 patient needed surgery after sclerotherapy for persistent recurrence of the cyst, and she had a natural conception after the surgery. So 80.39% conceived through IVF and IUI. 41 out of 51 patients, infertile patients, conceived. Out of 51 infertile, 38 patients conceived and delivered through IVF and IUI after treating endometriosis with sclerotherapy. 3 conceived through natural conception. So 31 patients delivered in our hospital and 10 delivered at their mother's place. So this is the graphical representation: 110 aspirations, no recurrence in 102, Infertility in 51, 41 achieved fertility or became pregnant and delivered, and 4 patients didn't turn up for follow-up. The advantage of sclerotherapy, the main advantage is that fertility treatment can be resumed in the same month or the very next month after aspiration. And this is a systematic review and meta-analysis by ASRM 2017. It was published in Fertility Sterility. And it concludes that sclerotherapy for ovarian endometrioma may be considered in symptomatic women who plan to conceive. And this is yet another study that is published in Human Reproduction in 2019. And they were using metronidazole as a sclerosing agent into the mice. And this is another study that is published in Fertility Sterility, and it took into account 32 patients, and 24 were observed out of 32. 22 had a complete resolution, and in vitro fertilization was performed in 28 patients. So ongoing gestation has resulted in 16 from the next cycle. So the pregnancy rate was 57%. They used 5% tetracycline as the sclerosing agent. Since tetracycline is not available in India, I couldn't use that. Instead, I used cephalosporin sulbactam and leuprolide. And off dates, that is recently we were using metronidazole also. This is from New York Fertility Institute, where Dr. Khalid Sultan and Dr. Majid Fay in New York Fertility Institute practiced sclerotherapy for the past 25 years. And they use as a first-line treatment for people suffering from endometrioma and infertility. So these are some of the centers in the world where sclerotherapy is being carried out. And this is our data. And this was my first patient for whom I coined this sclerotherapy. And in the first month itself, she had an embryo transfer and she conceived, and she delivered exactly 9 months after the embryo transfer. And to my great surprise, she had a natural conception in the very next year during lactation amenorrhea itself. And I have followed her up for 5 years, and she had never had any recurrence of endometriosis. And she is now the proud mother of 2 children. So our results are quite impressive. Achieved fertility in 41 patients out of 51, and the success rate is around 80.39%. So sclerotherapy using newer sclerosing agents prevents repeated surgeries, and it's a boon to the frustrated endometriotic patients. I have not encountered any complications in this modality of treatment. 2 weeks ago, I attended a webinar on recurrent endometriomas, and it was the speaker was a renowned laparoscopic surgeon, where she told that doing aspiration of endometriomas vaginally is a crime. Yes, if you do it without antibiotic coverage, without properly knowing the technology or the technique, and without doing it under aseptic precautions, then it will be a crime because it will result in ovarian abscess. So what are all the treatment, either the medical, surgical, sclerotherapy, anything, to achieve fertility, we have to go for ART. So the intrauterine insemination, shortly after ablation of minimal or mild endometriosis, using any one of the therapies, clinical pregnancy rate per treatment cycle and cumulative birth rate were similar in endometriosis and in unexplained infertility, indicating a detrimental effect of endometriosis on fertility. IUI is typically not offered to women with moderate or severe endometriosis because of a probable effect on the fallopian tubes. According to the British Journal of Obstetrics and Gynecology, 2 more recent meta-analyses on outcome of IVF in endometriosis, live birth rate was found to be similar in minimal or mild endometriosis and other indications for IVF, whereas in patients with moderate and severe endometriosis, the results were inferior, including fewer oocytes retrieved, lower implantation rates, and low birth rate. So what are the stimulation protocols we can follow for IVF? Previously, it was advised the ultra-long protocol, down regulation for 3 to 6 months with GnRH analog in women with endometriosis, increases the odds of clinical pregnancy by more than 4-fold. The GnRH agonist protocol with all stages of women with all stages of endometriosis who underwent luteal phase GnRH agonist downregulation followed by IVF for ICSI treatment had a similar pregnancy and live birth rate and lower miscarriage rate compared with women with tubal factor infertility. GnRH agonists prevent deleterious effects of premature endogenous LH surge, but also suppresses a number of inflammatory cytokines, modulate the natural killer cells of uterus, and also reduce the uterine aromatase production. So after the invention of GnRH antagonists, we prefer to use the antagonist protocols. They are good choice for poor responders and patients with poor ovarian reserve due to ovarian endometrioma or after its surgical excision in IVF cycles, as they cause immediate suppression of the LH surge. So the guidelines, that is the GDG, that is the guideline deciding group, recommends the use of ART for infertility associated with endometriosis, especially if tubal function is compromised or if there is male factor infertility and or other treatments have failed. In infertile women with endometriosis, clinicians may offer treatment with ART after surgery, since cumulative endometriosis recurrence rates are not increased after controlled ovarian stimulation for IVF and ICSI. The DDG recommends that clinicians counsel women with endometrioma regarding the risk of reduced ovarian function after surgery and the possible loss of ovary. The decision to proceed with surgery should be considered carefully if the woman has had previous ovarian surgeries. They can be opted sclerotherapy. The effectiveness of surgical excision of deep nodular lesions before treatment with ART in women with endometriosis associated infertility is not well established with regard to reproductive outcome. The risk of complications during pregnancy are so much with endometriosis, although the results of epidemiological studies are contradictory. Some evidence is suggestive of an association between endometriosis, miscarriage, placenta previa, preterm delivery, and small for gestational age babies. The risk of contamination or infection during IVF cycles and iatrogenic injury after oocyte retrieval or inadvertent puncture during oocyte retrieval may cause infection in cases of ovarian endometrioma. Until recently, only 14 cases of infection after oocyte retrieval have been reported in 9 studies, although it is possible that this complication is underdiagnosed. That's why during our stimulation protocols, if the patient is having endometriomas, we aspirate it in the previous month itself and start the stimulation in the next month. Or we do during stimulation, if suppose they develop the endometriomas before retrieval or a few days before retrieval, we aspirate the fluid and we put in the sclerosing agent. This does not alter the quality of the oocytes, and we do everything under antibiotic coverage. So this complication never arises in our own pickup. So what is the treatment algorithm? So infertile women with suspected endometriosis have to go for the infertility workup and know the ovarian reserve by doing AMH and AF antral follicular count. If suppose there is poor ovarian reserve or the age of the patient is more than 35 or nearing 40, you have to advocate IVF and ICSI. And if there is suspicious or minimal or mild endometriosis, you go for surgical treatment. And you can do controlled ovarian stimulation plus IUI for 3 or 6 cycles if the patient is young. And suppose the patient is having recurrent endometriomas or the endometriosis is moderate or severe, then you have to go for sclerotherapy and followed with IVF and ICSI. So the summary and recommendations are, there have been a few published randomized trials of management of infertility in endometriosis. Before planning fertility management in endometriosis patients' age, duration of fertility, other combined causes of infertility, ovarian reserve, severity of pain, and the stage of endometriosis should be thoroughly evaluated. And sufficient information about the patient's condition and management options should be provided. When laparoscopy is performed, the operator must ablate or excise the endometriotic lesion and restore normal pelvic anatomy as completely and as safely as possible. The surgery might improve fertility, however, repeated ovarian surgery should or ought to be avoided. If natural conception does not occur within 1 year after surgery, the clinician may consider ART. In infertile younger patients with stage 1 and 2 endometriosis, expected management or controlled ovarian stimulation with IUI after surgical management must be considered. But if patient is more than 35 years of age, the COS with IUI or IVF may be preferred option. In infertile patients with stage 3 and stage 4 endometriosis, surgical management may be recommended. However, ART can be an effective alternative for older women with advanced stage or recurrent endometriosis. Clinicians are advised to assess ovarian reserve prior to deciding whether to surgically remove the endometriotic lesion. It is recommended to measure the AMH level at least 3 months post-operatively to decide on an optimal treatment plan. Individualized care provided with this in mind to women with endometriomas prior to IVF can help optimize their pregnancy outcomes. The criteria for specific values of ovarian reserve markers used in decision making regarding surgical treatment have not yet been established, and further research should be conducted. So to conclude, endometriosis is an ever-challenging disease affecting all age groups from adolescent to perimenopausal women. Individualization of treatment is a must according to the severity of the disease, tolerability of the patient, and the desire for fertility. The standard treatment for symptomatic endometriomas more than 5 centimeters is laparoscopic surgery. Medical therapy is, however, often used before surgery to reduce the size of the lesion and the extent of operations. Dynages, the wonder molecule, is preferred most for patients' compliance and quicker return of fertility. The advantages of sclerotherapy: it is minimally invasive, cheap, cost-effective. It's an OP procedure, and there is less ovarian manipulation and less ovarian damage. There is no low recurrence rate and prevents the drop of AMH. It resumes fertility quickly. The very next month itself you can try and avoid all the general anesthesia complications. So I want to conclude with a statement that sclerotherapy using newer sclerosing agents is a new frontier in the management of recurrent endometriomas. Thank you so much for your patient listening. Questions and doubts are invited. Am I audible?
Yes, ma'am, you are audible.
Yeah.
You are audible, ma'am.
Is there any questions or doubts?
Ma'am, there are no questions in the chat box. If anything, ma'am, over and above any message you want to give to the entire group, ma'am? So it
Yes,
will
of
be better.
course. Yeah.
Yes, ma'am.
Yeah, we know that endometriosis it's an enigma, and it's known for its association with infertility and recurrence. And surgical management, of course, is very useful for the diagnosis of early endometriosis and to tackle the severe and moderate endometriomas or endometriosis. And of course, when you do the primary surgery, it should be meticulous. The anatomy, pelvic anatomy should be restored to its normalcy, to the maximum. And you have to stage the endometriosis properly. And you can use the endometriosis fertility index to assess how the pregnancy rate will be, whether it will be good or bad. And we should not waste time in doing medical management and such things. We have to quickly give them the fertility before they become very bad, or when the ovarian reserve goes badly. It is they should not, because it's very known that endometriosis causes damage to the ovarian tissue, and their ovarian reserve goes there is poor ovarian responders. They are poor ovarian responders. AMH also will be very low. So we have to quickly tackle them. And we cannot keep on doing surgeries for recurrent endometriomas, because patients cannot afford, and psychologically also all the patients are much affected. And ovarian damage will be more when you keep on doing surgeries. So after the first surgery, if suppose they are getting recurrent endometriomas, better you go for sclerotherapy. If you do it properly under aseptic precaution and under antibiotic coverage, definitely it's a boon to all the infertile patients for suffering from recurrent endometriomas. And I had presented this in the Fertivision Conference 2019 and got the Best Clinical Paper Award for this. And I also presented this in Las Vegas in the conference called the Placenta, and I was appreciated for that also. I had a certificate of presentation of this. So it's a research, and we are keeping on doing this, and it's an ongoing clinical study, and I hope rest of my colleagues and friends will be also benefited by trying this. And only thing, it's just like doing an over pickup. And I have not encountered any infection or any complications in any of my 112 patients for whom I have done this aspiration using sclerotherapy.
Ma'am, on those same lines, there is a query from the Dr. Jayachitra, ma'am.
Okay.
Ma'am, she's asking, do you repeat sclerosis therapy when the patient has recurrence, and how often do you do it, ma'am?
In my presentation itself, I told you I have done it for 3 patients. And one of my patient, I had 5 aspirations. 5 times I have done this. And recently only I have done embryo transfer for her after home pickup in 2 months ago. And she is on treatment. This is the 10th day of ET. I'm waiting for the results. Okay. So, yeah. And even during my stimulation also, repeated, 5 times I have repeated for her.
5 times in a span of?
Yeah, in the same manner, in the transvaginally only.
Okay. No, in the span of how many months, years? So
yeah, yeah. She was getting treatment for the past 1.5 years.
Okay.
And she had never undergone laparoscopy.
Okay.
This is a primary treatment for her. And she was referred to me by one of my senior colleague, Dr. Revati Janakiraman. And now the patient had undergone sclerotherapy and ET also, embryo transfer. And I'm awaiting results. And one, my patient, that is Srisha, she is a lady lawyer in High Court, Chennai. And for her, I have done 3 aspirations because she had recurrent endometriomas. Because of the severe dyspareunia, she had undergone divers. And after being, after this sclerotherapy, now they are thinking of getting remarried because the pain has completely gone and they are looking for a second marriage.
Correct.
So there are so many histories of each 110 patients. I have separate histories of such things.
Exactly, ma'am. What is the clinical expertise? What you have 110% treatment and sclerotherapy is the need of the hour, ma'am. So that is definitely you have put a light on it, which you presented in the clinical paper, ma'am.
Yeah.
Thanks for your valuable insights, ma'am.
Thank you so much for giving me this opportunity. And I thank all the
Thank you,
audience
madam.
for patiently listening to this. Thank you so much.
Ma'am, this was a beautiful talk and a very interesting topic like endometriosis and infertility. The vicious cycle goes on. So
Yeah.
from there, I got the insights, ma'am. We got the insight that sclerotherapy is the new trend where it is not only medical therapy, sclerotherapy is gaining up pace, which you have told, ma'am. So with this, Walter Bushnell stands committed for such kind of scientific piece, ma'am. So we like to get associated. Thank you, ma'am. Thank you for the lovely
so
evening,
much.
ma'am.
Thank you so much. Thank you so much.
Thank you, ma'am.